So, hi everyone. I hope you can hear me and see me. My name's Freya. I'm one of the pediatric leads with working with Mind the Bleep. I'm currently an F2 working in the NUH Trust. So, today's talk is going to be about neonatology and cardiology. So, without further ado, let's get started. So, we're going on to our first question. So we've got a 29-year-old woman who attends her follow-up appointment after having her dating scan done, where she chose to have the combined test screen done as well, the results of which are below. So we can see that she's had a scan which shows increased nuchal translucency and low Papa A and a high beta HCG, and it comes back with a total risk of 1 in 100. She is currently 14 plus 1 gestation and is very anxious. And the SBA is asking which of the following would be the most appropriate test to offer as the next step. So we've got A, quadruple test, B, non invasive prenatal testing, C, no further test required, D, chorionic villus sampling, and then E, amniocentesis. So I'll give you a few seconds to kind of think about that. And then we can move on. Okay. So the correct answer is non-invasive prenatal testing, and that's because this has the highest sensitivity for picking up trisomies in terms of all the screening tests. So what this question is essentially getting at is that we've got a woman who has come back with a risk of 1 in 100 pregnancy that has a trisomy in it. Now, based off the findings of this, with a high beta HCG that is only associated with Down syndrome. So that's what this question is kind of pointing towards. Um, in terms of what would be the next best test to offer, so non-invasive prenatal testing is not a definitive test. It is a screening test, like quadruple test and combined test, but it has a much higher sensitivity. And therefore, because of the fact that it's also not invasive, and it's this pregnant at this point in gestation, we're over the 10-week window, this test would be the best next test to offer. Why the other answers are not correct? Quadruple testing is just another test like combined tests. It actually has an even lower sensitivity, and it can only be done after 15 weeks and prior to 20 weeks. So it's not in the correct window for this question. We do need further tests to be done because this baby does have an increased risk of trisomy because it's greater than 1 in 150, which is our threshold for further testing. And then D and E are definitive ways to see if a baby has trisomy, but they are both invasive and they may not necessarily be needed. Because they're invasive, they're associated with risk factors, and because non invasive prenatal testing has such a high sensitivity. That's not much different to the sensitivities of chorionic villus sampling and amniocentesis. There isn't much benefit to doing those tests before non-invasive prenatal testing, essentially. So this slide, I hope, explains some of um, the all the different tests involved in antenatal scanning and testing because I found it quite confusing at med school. So if as a default, every pregnancy, a woman should be having a first scan, which happens as the dating scan, which ideally should happen between 11 and 14 weeks of gestation, but not all women book in their pregnancy at that point. So it may happen a bit later, but then some of the features of the dating scan may not be used. The dating scan dates of the gestation also align with the combined test dates. So it's quite useful to see what the gender, the sex of the baby is, what the gestation is, and what the estimated delivery date is, and whether this at this point the fetus is compatible with life in utero. So that's quite important. And then it also is quite important to remember that the nuchal translucency can only be seen in this time frame of the dating scan as well. So that's a good way of remembering for me that the nuchal translucency is a component of the combined test. So combined test and dating scan, and nuchal translucency all have the same window of overlap. So it's useful to remember that when you're remembering the differences between all these things. And then here we've got the table basically comparing the different trisomies. So like I already said, the best way to remember for me is to differentiate Down syndrome from the other two trisomies is to see the beta HCG. If it's high, then it's Down syndrome. And then differentiating Edwards and Patels is a little bit harder, but again, it's based on beta HCG as well. So moving back to the flow chart, if, for example, we've got a woman who's decided to go for the combined test, she will get a result of a risk of trisomy either less than 1 in 100 or greater than 1 in 100. And if it's greater than 1 in 100, like the SBA suggested, we will go down the path of non-invasive prenatal testing. This test, it's different to the combined and quadruple test because it gives your result as a qualitative measure. So it's a low chance or high chance of having a baby with a trisomy, which is different to the numbers you'd get for the quadruple and combined test. If, for example, you've got a baby with a high chance of pregnancy, then you would go on to do your more definitive and invasive testing, like chorionic villus sampling and amniocentesis, depending on the gestation. If you've got a baby with a low chance, then you would go on to do the anomaly scan, which forms part of all pregnancies. And it's basically a head to toe scan of all the most important organs in the baby's body to see if there's any issues with them. An important thing to remember, I think, is for non-invasive prenatal testing is it actually can measure a lot more than just trisomies. It can look at the gender of the baby, and it can also talk about the microdeletions in the chromosome, so it can indicate other conditions the baby may have. But those features are only offered, like they're only unlocked if you go private. They're not offered on the NHS. For the NHS, the purpose is solely for trisomy diagnosis at the minute, or trisomy likelihood, not necessarily diagnosis, because you can only diagnose with chorionic villus sampling and amniocentesis. So moving on to our next question, we've got a 36+2 gestation baby who is born after an uncomplicated pregnancy. At 1 minute, his fingers and toes are blue, he is floppy, and he's having weak, irregular gasps. He is grimacing when he's being dried and stimulated. He has a pulse of 90 beats per minute. What is his APGAR score? So I'll give you a few seconds. Okay, so the correct answer is 4. So APGAR is another thing like the tables for before. You kind of just have to remember, unfortunately. The best way to go about remembering it for me is that APGAR itself is an acronym, so that's helpful to remember what each thing is being scored for. For each letter, you get 2 points maximum, and the more points you get, the more normal the baby essentially is, and the less you have to be concerned. APGAR is always repeated at 1 minute and then 5 minutes. That's just standard, irrespective of what your score is at 1 minute. So in this example, we've got a baby with a body that's pink, but the limbs are blue. So that's obviously concerning, but not the most concerned you'd be because the body is still pink. So that scores you 1 point. Then P is for pulse. So you've got a pulse of 90, which is less than the threshold of 100 beats per minute, which we'd consider normal. So the baby would only get 1 point, not 2. Then you've got baby grimacing. So G is for grimace. So that essentially means when the baby is being dried and stimulated, how vigorously are they crying? Is there a response? Or are they just kind of grimacing to the response? And if there's only a grimace, then that would only get you 1 point. A is for activity, so essentially muscle tone. So if the baby's got active movements, then that would get you normal points. However, if there's floppiness at all, then that would get you no points. And then R is for respiration. So if there is weak, irregular gasps, then that would only get you 1 point as well. And then you just total up your score, and then you get your APGAR, and then you repeat it again at 5 minutes. So in this specific baby, what would be the next best step? So would it be to continue to observe and repeat the APGAR at 5 minutes? Would it be to give 100% oxygen via face mask? Or provide 5 inflation breaths with a bag valve mask? Or would it be to start compressions immediately? Or would it be to dry and stimulate the baby vigorously? Okay, so the correct answer is C, provide 5 inflation breaths with a bag valve mask. So A, yes, you would repeat APGAR at 5 minutes, but we need to do something in the interim. The baby is too sick just to wait and observe. B, that option does not form part of the NLS pathway, which I'll briefly talk about in the next slide. D, so in a baby, which is quite weird, and I actually only understood this when I did peds as an F1, a heart rate less than 60 beats per minute is enough to start chest compressions in a baby, in a newborn. That is weird because I know in adults we'd only do it if there was no pulse, but this is true for children. So less than 60 beats per minute in a baby, you do chest compressions, but not above 60 beats per minute, like in this question. And drying and stimulating the baby vigorously would be the correct first step, but in this case, the baby's already been dried and stimulated, so you'd move on to the next one. So knowing the neonatal life support, you really do not need to know it in the details that you would clinically, but there are a few steps are worth remembering. So the first one I think is that drying the baby is the first action, like I've already said. The second one is that ventilation breaths are more important than compressions in pediatrics. This is true of all types of pediatric life support. And it's always 5 breaths first. And the reason why ventilation breaths are more important is because of the fact that in pediatrics, arrest is more likely due to respiratory cause than a cardiac cause. And then when the heart rate is less than 60 beats per minute, that's when you would start compressions. And different other types of compressions, it's a 3-to-1 ratio. And you also do the compressions differently, like you use 2 fingers. Sometimes you can do this depending on how big the baby is, but you won't really need to know that unless you're doing ILS, pediatric ILS. So this flowchart kind of goes through the steps that I've already spoken about. If when you're doing compressions and there's still no response after 30 seconds of compressions, that's when you'd consider making sure that you've got access to the umbilical vein, because it's a massive vein and it's essentially just a big like a big line through there, and you can give adrenaline and it establishes access quite quickly compared to cannulating a newborn, which is challenging. And moving on to neonatology now, in more detail. So this timeline that I've created, it's more just to kind of help you think about the issues a premature baby would have. So for example, if we think about like the key points, and these are obviously not the whole points in the journey of pregnancy, but for example, the neural tube closes at 4 weeks, which is why it's really important to have folic acid prior to conception, because I mean, by the time you realize that conceptions happen, your neural tube's probably already formed, which is why it's really important to keep that folic acid before pregnancy. Your kidneys start producing urine in like the fetus's kidneys start producing urine, therefore amniotic fluid, around 9 to 10 weeks of gestation. And that's important because after this point is when we start scanning the baby with an ultrasound. Prior to this point, there's no fluid around the baby. We wouldn't really be able to see what's going on. But the presence of the amniotic fluid allows us to scan the baby. The dating scan is important because the external genitalia is usually developed by 11 to 14 weeks, which is why it helps determine the sex of the baby. Then you'd have the anomaly scan as per usual in the second trimester. And important features now to remember is that the first point of viability would be around 22, I'd say late 22 to 23 weeks. That would be the first point of viability in some babies. But there are loads of things after this point which still haven't been achieved, which is why prematurity is a massive issue. One of the things that's worth remembering is the skin is not fully formed yet. And I know that we all know that skin helps protect against infections, but it also protects against heat loss, and it helps make sure that we're kept warm. And all of that happens much later in your pregnancy timeline. So your hypodermis fat deposition only occurs around 32 weeks. Most famously, premature babies find it very difficult to breathe because they don't have enough surfactant, and surfactant production only starts around 25 weeks of gestation, and it continues all the way till the end of the pregnancy and a little bit into the postneonatal period. But even a baby that's like 34 weeks, every week that you get is really helpful because a lot of surfactant is produced in that time. So skin for thermoregulation, and then lungs for breathing, and then also your immunoprotection. So premature babies, their immune systems aren't fully developed yet. Therefore, and the reason their own innate immunity is not developed yet, but additionally, plus, the baby's not received the IgG antibodies from the mother until quite late into the third trimester. So I know it says on the slide that it starts around week 28, but it actually reaches maximum around week 32. So that's when the baby is actually immunoprotected. Another thing which I didn't realize until starting like doing pediatrics is that babies only learn to suck and swallow, like the reflexes for feeding, much later. And the reason why that's important is because babies also suffer with jaundice. Now, that's not something I'm going to be talking about in this presentation, but I will come back to it in the next talk we do. But that's something important to remember, because the more the baby feeds, the less likely the baby will have jaundice, essentially. So this is another slide kind of summarizing everything I've said in maybe a different format that you might like. So prematurity is any baby born before 37 weeks gestation, and then there are different classifications for it, and these are basically the classifications. Each week that you gain in the pregnancy is important for different things, and it makes a difference on your survival and the kind of complications that you have. So your risk factors for prematurity include multiple pregnancies, lots of things to do with maternal infection, like placental insufficiency, or conditions in the mother like eclampsia and diabetes that can cause prematurity as well. So most of them are to do with previous pregnancies or then issues in the mother, which I hope will be covered in your obstetric talk as well. And then you've got the actual system issues that can go wrong. So like I've already mentioned, in respiratory, you've got surfactant deficiency, therefore preterm babies are at risk of respiratory distress syndrome. Then neurology-wise, they've got a fragile germinal matrix. So that's usually where all the intraventricular hemorrhages happen. And that can, depending on the severity of the intraventricular hemorrhage, can cause, for example, cerebral palsy as well. And then you've got metabolic issues. So you've got low glycogen stores because they've just not been developed yet. And then you can have higher risk of neonatal hypoglycemia and other issues of not knowing how to respond to fasting states properly as well. And the thermoregulation, which I've already covered. So in the previous slide, I didn't talk about this, but your CNS regulation of temperature happens very late in pregnancy. So that, coupled with the fact that the baby doesn't have enough insulation from the fat in the skin, predisposes a premature baby to losing heat quite quickly. And then hematologically wise, you've got reduced erythropoiesis, and then you get something called anemia of prematurity. And then finally, infection predisposes you to neonatal sepsis, something that I've already spoken about, A, because the baby's immune system is not fully developed yet, and also B, because of the fact if the baby's born prior to the IgG transfer via the placenta, it's got a high risk of getting sepsis. So moving on to our next question, we've got a 30-week preterm infant who develops rapid breathing and chest recessions shortly after birth. They are grunting and have reduced air entry bilaterally. A chest x-ray shows diffuse ground glass appearance with air bronchograms. What is the most likely diagnosis? So I'll give you a few seconds. So the correct answer here is respiratory distress syndrome, something that I've already touched. So It's a premature baby, it's a 30-week-old, so less than 37 timeframe that we have. And the chest X-ray findings are in keeping with RDS. And the reason why the others are not correct for the most part is because it's not in the correct time frame, like transient tachypnea of the newborn. That would happen in term babies. Meconium aspiration, there's no real mention of green amniotic fluid. There would be some other signs, and the chest X-ray would not show that. And the pneumonia, this happens quite soon after birth. They need to, have a little bit of time to catch pneumonia, either from the like as an infection from the mother or something else. And then the chest X-ray findings for a pneumothorax would be different as well. So respiratory distress syndrome is basically something experienced by preterms, and it's to do with the surfactant, lack of surfactant that we have produced from our type 2 pneumocytes. So essentially, a surfactant deficiency increases the surface tension in your alveoli, and that causes collapse, and it reduces the compliance. So when you're breathing in and out, the alveoli are less able to do that as well. And that essentially causes hypoxia, it causes pockets of alveoli not functioning as well. And essentially, because they're just moving so rigidly, like on a microscopic level, you get these hyaline membrane deposits, and that, imagine like a stiff balloon. It's not able to expand like it should, and it's not able to come back to the correct size, so it just collapses after. And that's really the issue with RDS, and surfactant helps prevent that from happening, but they don't have a lot of surfactant, which is why the issue happens. So risk factors is prematurity, especially prior to 34 weeks, because like I mentioned in my first slide, around 34 weeks to 35 weeks, we should have a baby that could have enough surfactant to not have RDS as their main problem, essentially. Then maternal diabetes as well. Then you've got C-section with no labor, and then males, a second twin. All these things cause some changes that help essentially increase the steroids that help with surfactant production in the baby. So to prevent this, steroids are given, and they're given as an iron injection to the mother around 24 to 34 weeks for prevention of RDS, especially in a mother who has got risk factors like eclampsia or something that could mean that she has a high risk of having a premature baby. Clinical features would be things like sorry, that's actually a typo, but clinical features would be things that show respiratory distress like you would in a newborn baby. So high respiratory rate, you've got nasal flaring, grunting, subcostal, intercostal recession. So these are things my colleague Alex touched on previously in the talk on respiratory system. And they would happen quite quickly after birth. And this is your chest X-ray finding showing the diffuse changes that the previous question mentioned. And in terms of the management, we would have to prevent. So essentially, there are things that we can do to help the baby breathe and ventilate in different ways. Now, CPAP is now pretty much CPAP and using. Previously, we could give, so in a baby like this, if you've got RDS, the issue is lack of surfactant. So we can give surfactant to babies. Now, previously, in order to give surfactant to the baby had to be intubated and ventilated, but that's no longer the case. Now you can give surfactant to the baby without wiring that. So it's a new form of giving it, because it's now done all over the UK. It's not in every baby. It depends on how much they're struggling with their breathing as well. So you can either give, it's called lysis, you can either give the surfactant through some type of intubation, or you can give CPAP essentially. And CPAP helps the alveoli expand and keep its shape, because they provide a continuous pressure to the alveoli so they don't collapse, which is something that we need to prevent in RDS. Also making sure that the baby is like metabolically stable. So making sure that their risk of infections is quite low as well, because as soon as you add infection into the mix with RDS, you get a much sicker baby a lot faster. Okay, so then we've got the next question, which is 2-month-old with bilateral sensory neural hearing loss. Her mother, who has no health complications herself, mentions her child was born with a rash, and scans during the newborn period showed periventricular calcifications. What is the most likely cause of her hearing loss? So the correct answer is CMV, and that's because A, it's the most common torture infection to cause hearing loss worldwide. So it's a really important one for you guys to know. And the other answers are not as correct because I think this table kind of explains it better. So I think it's worth, because this can be quite overwhelming. So the key thing to do with this is to remember a few things that is very highly associated with each of these torture infections. And so for toxoplasmosis, it's extremely associated with hydrocephalus, and you get different eye changes. So you get chorioretinitis, and you don't normally have hearing loss. With syphilis, you get a baby with like a rash, hepatosplenomegaly. It's got also bony lesions as well. Like the baby looked completely different to the others. Rubella and CMV have a very similar rash with the blueberry muffin rash, as you can see in this image here. But the difference with rubella is it also affects the heart. So a good way to remember it is it does cause sensory neural hearing loss. So it affects your ears, your heart, and your heart, and your eyes. There we go. So it causes bilateral cataracts. And then CMV, which is the one we've already spoken about. So periventricular calcifications are very sensitive to this. And then you've got the sensory neural hearing loss as well. And then a baby with HSV would present extremely like sick. They usually present with like hepatitis and DIC, and their rash is like in this lower picture, it's a vesicular rash. So moving on to our next question, we've got a 1-day-old term baby born to an uncomplicated pregnancy and labour, presenting to the hospital with lethargy, poor feeding, and temperature instability. Examination shows mild respiratory distress and reduced tone. Blood cultures have been taken. What is the most appropriate empirical antibiotic combination? So the correct answer here is D. We've got benpen and gentamicin, and that's because it covers the three main organisms that would most likely cause sepsis in this 1-day-old baby. So neonatal sepsis is obviously a very important thing to cover, but it's not as different. It's not that different to sepsis in any other child as well. The most important thing to remember is the organisms essentially. So if the sepsis has started within the first 72 hours of life, it's usually acquired from the mother. And it's called early onset sepsis. And if it's after 72 hours of life, it may be hospital or community acquired. So early onset organisms include GBS. So in the stem of the question, you might have something like foul smelling placenta, or she had a previous child with an infection, or a swab came back positive during pregnancy. Then E. coli is another very common cause of sepsis in the early onset period, and it's got the highest mortality as well. Sometimes it's associated with a condition called galactosemia, though I can't really imagine you having to figure that out. It might just state it as a question in your STEM. Then you've got listeria, and that's associated with unpasteurized dairy products. So this is the reason why the answer here, the benpen, is needed, because it covers listeria, and the gentamicin is important for covering E. coli as well, and GBS is covered by benpen quite well as well. And then late onset organisms are these ones. A lot of these are dependent, other than Staph aureus, are dependent on whether the baby has spent a prolonged time in NICU. So yeah. Or for example, if the baby has another condition like cystic fibrosis. And then these are some of the risk factors for GBS. So like I already mentioned, they might mention this in your STEM. So if the mum has had a previous colonization with GBS, so previous swabs have come back positive, or a smelly placenta. And then always remember that a risk factor for any infection is a preterm baby, and that's because, like I've already mentioned, lack of IgG, and then their immune system's not as developed. And then the clinical features of sepsis. Now, can look a bit different to sepsis otherwise. So, yes, you've got the increased work of breathing that we've got the tachypnea, the grunting, the nasal flaring, things like that. But then you've also just got lethargy, floppiness in the child, lots of temperature instability. So, you may have hypothermia as well as a higher temperature and fever. Um, and then you've got things like jaundice and then low glucose as well. And then these are some of the investigations that you would do. So you'd start off with the standard FBC, USNE, CRP, LFTs, but you may also do a metabolic screen, especially if you do a gas and the glucose has come back low or the lactate has come back high. There are lots of metabolic conditions in the newborn period that are worth scanning for. And then you do blood cultures as usual and doing a chest x-ray. And then the only difference in a newborn is you do an LP because they're very susceptible to meningitis. And then the management varies trust to trust, but for your exams, no Ben, Pen, and Gent. And then the management otherwise is similar to sepsis, so oxygen and then NICU and PICU escalation if needed. So now we've got a 2-hour-old baby with macrosomia, and they're noted to be jittery by the midwife. She has had stable observations otherwise, and the baby has had a poor feed but has a normal tone and color. The mother has received IV morphine during labor. And then, what is the most likely cause of this jitteriness? So the correct answer is B, neonatal hypoglycemia, because we've got a macrosomic baby with jitteriness. So opioid withdrawal would be a good differential, but it would be a bit after. So it'd be 24 to 48 hours after birth. It wouldn't be 2 hours after. Um, and then just briefly touching on neonatal hypoglycemia. So the exact values of what counts as hypoglycemia does vary trust to trust, but the causes are generally because in utero you've got a baby that's had a constant supply of glucose from the mother, and then suddenly the baby's taken out of that environment. They might not know how to basically make their own food, figure their own stuff out. That's a good way to kind of remember it. And they also have a very high metabolic demand in this period. So they're not good at conserving energy and they're not good at making energy, which makes them susceptible to hypoglycemia. In diabetic mothers, they are more at risk because of the fact that the mum's blood supply, like blood, has such high levels of glucose anyway, which means that the baby responds to that by creating high levels of insulin. Now, insulin, as you guys might remember from preclin, is a growth factor, but this insulin's a big molecule, so it can't cross the placenta back to the mother. So the levels of insulin remain high in the baby, which is why diabetic mothers make macrosomic babies because of the fact insulin is a growth factor. And then you go to birth and the baby has really high insulin but no glucose, and it can't really figure out how to make glucose. Therefore, it has hypoglycemia. And these are the risk factors associated with it. And this is a flowchart essentially going through what to do if you've got a baby with low glucose. So it depends essentially on whether the baby is symptomatic. So a jittery baby would be symptomatic. So the approach would be to follow and give buccal glucogel. And if there's improvement, then to go and monitor and provide supportive care. However, if there's not any improvement, to go down this flowchart and then give an IV fluid challenge of 10% dextrose, and then consider doing a screen if it's not resolving. And then you've got a term baby that's reviewed on the postnatal ward due to tachypnea shortly after birth. She is pink, maintaining normal oxygen saturations on room air and is mild subcostal recession. There is no maternal fever and pregnancy was otherwise uncomplicated. A chest x-ray shows prominent pulmonary vascular markings. What is the most appropriate management? So I'll give you a few seconds. Just for the sake of time, I am going through these questions a bit quicker, but I hope that you can still come back to them. So the correct answer is to provide supportive care and monitor on the ward. So in a term baby, if they're struggling with tachypnea after birth, the most likely cause in your questions will be transient tachypnea of the newborn. So your risk factors would be an elective C-section, maternal diabetes, because again the baby's bigger, and it affects the level of steroids. Now, steroids help clear the lungs out of the fluid in the post, like in the period right after birth. So therefore, it's quite important because in transient tachypnea of the newborn, essentially what happens is you can't clear the fluids which is in the lungs, which is present in utero, and therefore the baby struggles to breathe. But it's essentially resolved by itself with some mild oxygen help and just some observation. So not much is needed to be done for it. But these, as you can see on this chest X-ray, this is like the level of fluid. You can see what the white arrow is pointing to. So yeah, the other options would not be correct because this baby is not. It would show other signs if there were any indication for sepsis, and you can't really have RDS in a term baby. Well, to be fair, I said you can't really have RDS in a term baby. You could technically, if they have a congenital reason why they can't make surfactant, but that's not going to come up in your exams. And then our next question is, we've got a 5-day-old baby who attends a community midwife appointment for a routine screening. The parents ask why the test is important as their baby appears well. Which of the following conditions included in the newborn blood spot test could lead to life-threatening metabolic decompensation if not detected early? So the correct answer here is medium chain or MCAD, basically. And instead of talking through this, it might just be easier to show you this table. So I think it is probably worth knowing briefly about these conditions. So phenylketonuria is a metabolic condition, but it usually presents a bit later when the child is 2 to 3 years old, because it's due to a buildup of something called phenylalanine, especially in the nervous system, and that causes severe intellectual disability. So it takes time to kind of get to a point where it would be noticeable. Congenital hypothyroidism is the most common out of all of these conditions, and it's because of no thyroid hormone, sometimes no thyroid gland, in these babies. Cystic fibrosis, which has been covered in a previous talk, is really important for respiratory care. The main principle with all these conditions is that you've got an issue from birth, which, if you don't help support it right away, can significantly impact the quality of your life. And if you do support it quite quickly, it could reduce the likelihood of you developing any of these things in some cases. So MCAD, which is the answer to the previous question, is essentially you have an issue with making and using fats for energy. So you don't want to ever get to a stage where you have hypoglycemia, because that's when the body inherently goes to rely on breakdown of fat. You don't want to go there, because in MCAD, if you've got that, then you don't know how to break down the fat properly. So you want to create always a steady state of good level of glucose, so you don't ever reach fasting state. So that's really important to remember, and it prevents basically life-threatening hypoglycemia, which is what is important to know. Similar with maple syrup urine disease and isovaleric acidemia, it prevents levels of these toxic compounds, which we don't know how to handle, essentially because there's something wrong in the pathway. It prevents their buildup so that we can manage it better. Okay, moving on to our next question. We've got a 7-day-old exclusively breastfed infant who is brought to the hospital after bleeding from the umbilical stump and prolonged oozing following a heel prick test. He is alert and well perfused, and these are his blood tests. And then we've got, what is the most likely diagnosis? So the correct answer here is vitamin K deficiency. And so you've got a prolonged PT and APTT. So that points to something that's not just affecting one pathway, but both intrinsic and extrinsic pathways. So hemophilia A and B would, your PT should be normal. A neonatal sepsis with DIC, you would expect that your fibrinogen would be quite low because it's being used up, say with your platelets. And then type 1 von Willebrand factor, usually normal APTT and PT, but I know in some cases you can have a slightly prolonged APTT, but your PT should not be prolonged. Therefore, and given that this is a 7-day-old, it points to vitamin K deficiency. So vitamin K is essentially transferred via the placenta, and as we know, it's a ADEK, so it's one of the it's one of the vitamins that require fats to absorb it, but the gut's not really there yet to start making and developing it on its own. And it's quite low in breast milk. The quantity of it in breast milk is quite low. Therefore, we usually give it, and that's the NHS prevention scheme, that it's given via an IM injection immediately after birth. And if the parents refuse the IM injection, you can give oral tablets, but that's it's different. So you give it at birth, and then 4 to 7 days after birth, and then at 1 month old as well. So you repeat it 3 times. And this is kind of like the manifestation of vitamin K deficiency, depending on the severity. So if it presents in less than 24 hours, that's quite severe case, and it's due to more other risk factors. So if there's maternal anti-epileptics, anti-TB, warfarin, and things like that. If it presents within 1 to 7 days, like in this case, it will present with bruising, umbilical stump bleeding, PR bleeding in some cases, and then 2 to 12 weeks usually only occurs in exclusively breastfed babies because it's not present in the breast milk, where it is in fortified like artificial milk. And there is a high risk of IVH with that as well. So it's quite important to prevent this where we can. And then we've got a question about sudden infant death syndrome, and which of the following is incorrect regarding sudden infant death syndrome? So you've got SIDS is more common in males, breastfeeding reduces the risk of SIDS, and using cot bumpers, so that's this thing here, that's the plaited woven lining to the cot, reduces the risk of SIDS. And then you've got premature babies are more likely to be affected by SIDS, and parents that smoke increase the risk of SIDS to their baby. So the correct answer here is using cot bumpers. So cot bumpers, I know they look like they would be smart, but they obviously can fall. Even if they're secured onto the cot by little threads, they can fall, and the baby can move, and it can suffocate the baby, essentially. That's the principle behind it. Also, sorry, going back to this image, it increases the local temperature for the baby, and if the temperature is quite high in the baby, that, as we know, babies are not good at regulating their own temperature. Even when they're born, they're still not the best at it because it takes some time, because it happens so late in the pregnancy. Therefore, it's important to make sure that we keep the area cool so the baby doesn't get too hot too quickly, because that can cause issues. So the most important thing to remember about sudden infant death syndrome, which is the unexplained death of an infant less than 1 year of age, and usually during sleep, it peaks in the postneonatal period, and B, we prevent it by making sure the baby their back is put to sleep. So that's the most important campaign that was started, and it massively reduced the number of deaths by SIDS. Essentially, making sure the baby is sleeping on a firm mattress, fitted sheet. The less cute, cuddly stuff is on the cot, the better. Breastfeeding helps reduce your risk of SIDS, and a smoke-free environment. So the ideal way to sleep with a newborn is that you keep the baby in their own cot, in a cot that's kind of empty and plain, and you keep that cot in your room, of not near any radiators, and that's the safest way to ensure that the baby has the smallest risk of SIDS. And if you are a parent that does smoke, then to reduce your smoking or stop it if possible. And these are some of the risk factors. So co-sleeping with the baby, which is common in a lot of cultures, which is when you sleep on the same bed as the baby, baby sleeping on their front or side, and then parents who sleep with their baby on the sofa, and things like that. And then if the baby is premature, low birth weight, and male for some reason, I'm not sure what the gender has to do with it exactly, but it is true that male, premature, and low birth weight babies have a higher risk of SIDS. And the reason why low birth weight and premature babies have a higher risk of SIDS is, like I've already mentioned, they're not very good at regulating their own temperature. So that's a good way to help you remember why those are risk factors. And then this is just a brief slide on NIPE that I've created. I'm not really going to go into the ins and outs of it, but essentially it's a newborn screening test which is done in all babies, and it's done at like around birth within the first 72 hours, and then repeated 6 to 8 weeks after, usually at the GP by the midwife. And it's a head to toe assessment of the baby essentially. So these are some of the key findings, and if you do find any of these, this is what you'd then do. For the sake of time, I'm not just going to read out exactly what it says, but I'm just going to go through the pertinent points. So something that a lot of people get confused about in the NIPE is the Barlow and Ortolani test. So that's essentially checking for developmental hip dysplasia. So you've got the Barlow test, which is what you're trying to do is you're trying to physically dislocate the hips yourself. So you see if the hips can be pushed out of the socket, so you push them back. And then the Ortolani test is you're trying to see if you can bring those hips back into the socket. And that each time if you do the Barlow test and if you do the Ortolani test, they'll make a clunking noise. And if that clunking noise is present, you need to do an ultrasound scan, which will usually be done at week 8, 6 of life, to check for DDH. And then these are some of the reflexes. So the reflexes are important to check essentially for the motor pathways and nervous pathways in most cases. So the Moro reflex is where you startle the baby, which is most famously known. And essentially, it's important to check for that there isn't an issue with the CNS essentially. And the rooting and suckling, which is where you like touch the baby's like cheek like that, and then they open their mouth and to that side, and that shows that they've got good feeding competency. And then the grasp reflex is good motor tone, so it's how tightly they grasp on. And then stepping reflex, which is here, shows you good neuromuscular junction function. Okay, now moving on to fetal circulation. So in fetal circulation, it is different to obviously circulation in the rest of their life. There are 3 main principles to remember. So placenta is where oxygenation happens. It does not happen in the lungs. Pulmonary vascular resistance is very high, and then your systemic vascular resistance is low. And the 3 shunts that help ensure that those principles are kept in place is you've got the ductus venosus, which is a shunt between the umbilical vein and the inferior vena cava, and it helps bypass the liver. Now, this is really important because the umbilical vein will have the highest level of oxygenation, and it does go through the liver, but because some of the blood can shunt across the inferior vena cava, this blood eventually is the blood that ends up reaching the brain and the heart first. So that ensures your brain and your heart have the highest level of oxygenation compared to the rest of your body. Then you also have the foramen ovale, which is between your atriums, your right atrium and your left atrium. And essentially, it's important to make sure that you bypass the lungs because that's not where the oxygenation is happening. So there's no need to really go to the lungs. The lungs kind of help themselves in that way because the vascular resistance is so high in the lungs that the blood doesn't even want to go there in the first place. And then you've got the ductus arteriosus, which is between your pulmonary artery and your aorta. Again, this means that it bypasses the lungs because the blood can go right from the right system into the left system. It doesn't need to go into the left ventricle either because there's no need to pump blood because your systemic vascular resistance is low. So we don't need to create a pumping system because the pressure is not high to pump against. At birth, what ends up happening is the baby takes his first breath. Now, in a normal vaginal delivery, the baby is also pushed out the vaginal canal, and that helps get all that fluid in the lungs out, and it reduces your pulmonary vascular resistance. At the same time, you've got your umbilical cord. Your umbilical cord is covered in this something called Wharton's jelly, Walton's jelly likes warm environments, and when the baby is born, the environment's obviously colder outside, so it contracts and it squeezes all these vessels at the umbilical vein, and all of that causes prostaglandin release as well, along with other things are released, and all these things essentially increase your systemic vascular resistance. So at birth, these systems are reversed. When previously in utero, your pulmonary system had higher pressure than your systemic system, when you get to birth, that kind of switches, and that means that blood will want to go into the lungs to become oxygenated, and that's why that's really important. So, what would we look for in the first 24 hours of life if we were suspecting a baby with a bad heart, essentially, with a congenital heart issue? So, you'd look for central cyanosis, you'd look for some issues with their breathing. You'd also check their femoral pulse to see if they had a weak pulse, or there's a delay between their femoral and their radial pulse. You would listen for any murmurs, and then you would also do like a top two assessment. You check cap refill, you would check if their feet and their hands were cold or pale as well, to see are all their extremities getting the blood like they should. And then this diagram points towards something quite useful to understand. So is meant to show pre and post ductal saturations. So essentially this, if you take the first image, I'm not really sure if you can see my cursor, but if you take the first image, this is like representing, so the one on the left is representing a normal situation. So you've got your ductus arteriosus, which should close within the first 24 hours to 48 hours of life. But because your systemic vascular resistance is higher than your pulmonary vascular resistance, which happens at birth, the blood from the aorta will want to go into the pulmonary artery because that's a lower pressure system, essentially. And that doesn't really cause any change to your oxygenation anywhere in the body. However, if this was happening in reverse, so if for some reason there was some issue in the lungs or the heart, which meant that the blood in the pressure in the pulmonary system was still higher than the pressure in the systemic system, what would end up happening is that the blood from the pulmonary artery would be going into the aorta when it hasn't received oxygen. And because the ductus arteriosus is situated after the brachiocephalic branch of the aorta, it means that the right hand should always have the most accurate oxygenation for the blood leaving the left side of the heart. And then the rest of the hands and feet will have potentially some blood that's been mixed in with some potentially deoxygenated blood if this system has been not what it should be. So if the blood is going from the pulmonary system into the aorta when it shouldn't be doing that. So the reason why pre and post ductal saturations are useful to measure is the pre-ductal saturations, the saturation in your right hand, is useful to compare it to the saturation in the rest of your arms and legs in a baby. If there is a difference greater than, for example, in my trust it was 8%, then that would point towards an issue with this shunt being in the wrong direction. And the reason it's in the wrong direction is because there's either an issue at the lungs or the heart. So if any of these signs are present and oxygen doesn't resolve the issues completely, then you have to think congenital heart disease until proven otherwise. So here we've got a question. A male infant is born at 39 plus 2 weeks gestation via uncomplicated vaginal delivery. At 1 hour of age, he's noted to be centrally cyanotic. He's breathing comfortably, but no significant respiratory distress. Oxygen therapy produces minimal improvement in oxygen saturation. His heart rate is 142 beats per minute and respiratory rate is 48. Pre and post ductal saturation is different by 2%. Heart sounds are normal and femoral pulses are palpated. So what is the most likely diagnosis? Tetralogy of Fallot, transient tachypnea of the newborn, tricuspid atresia, transposition of the great arteries, or truncus arteriosus. Also, we might just go over by a few minutes. I am really sorry about that, but it was a lot to cover. Okay. So the correct answer here is a transposition of the great arteries. So The key thing in this question is the baby is centrally cyanotic, which is the biggest concern here. In tetralogy of Fallot, though the baby may have episodes of cyanosis in their early life, usually it is not severe cyanosis right after birth. It's usually a bit later, and usually it's intermittent cyanosis as well, which we'll go on to explain. Transient tachypnea of the newborn, like I've already covered, is not associated with cyanosis at all. Tricuspid atresia may be associated with cyanosis, but it's also got a murmur associated with it. It's not really got this picture, and its pre and post arterial saturations may not look like this either. And truncus arteriosus is not associated with isolated cyanosis right after birth. It's usually associated with heart failure. So, explaining the two most important conditions I think you need to know at med school, tetralogy of Fallot or TOF being the most important one. So, essentially, what you've got in TOF is you've got four main things to remember. Now, the best way to remember it is you've got an aorta, an overriding aorta. So, essentially, what this means is your aorta normally should just have, should just be having access to the left ventricle. In this case, in TOF, you've got an aorta that kind of sits across both your left ventricle and your right ventricle. So it's got access to both. If you look at this diagram here, what that means is it causes a shift to this intraventricular septum to the right side of the heart. And that essentially opens up a gap between the aorta and the intraventricular septum, causing a VSD. So that way you can remember that you've got an overriding aorta and a VSD as a result of the overriding aorta. Additionally, your overriding aorta, that aorta has gone a bit more to the right side of the heart. What that means is your pulmonary trunk, where your pulmonary valves are, they become more stenosed because they don't really have the space to grow. So you've got pulmonary stenosis as well. Additionally, because you've got pulmonary stenosis and because your right ventricular cavity is smaller, given that your interventricular septum has all been shifted a bit right, you'll get right ventricular hypertrophy because your right side of the heart has to pump against the pulmonary stenosis to go into the lungs, which it will struggle to do that. So it needs to become hypertrophy to be able to do that. I hope that way you can remember the four key features. So the overriding aorta, the VSD, the pulmonary stenosis, and the right ventricular hypertrophy. Essentially, your degree of cyanosis depends on something called your degree of right ventricular outflow tract obstruction. So in this case, you've got a right ventricle. So here, it's got access to the pulmonary artery, for example. However, if there are some changes or if this VSD is much smaller, or there are some systemic changes in the pressures of the aorta, that will change how much the right ventricle is obstructed by and how much that tract, that flow of blood is obstructed by. So that's what you have to bring yourself back to every single time. So if there is cyanosis in TOF, you have to think, okay, if there's cyanosis, that means the right ventricular outflow tract is obstructed, full stop. And a good way to remember this in practice is TET spells. So TET spells are pretty much only seen in TOF. And the way they occur is that you've got a baby who, the best way in questions especially to remember it is you've got a baby who's crying a lot. When a baby cries a lot, it reduces your systemic vascular resistance. So the pressure in the aorta and this side of the heart is a lot less. If you've got some blood sitting in the right ventricle here, it wants to follow the path of least resistance. So it will start going to the aorta essentially. And that means that more blood is bypassing the lungs, more cyanosis will occur as a result. So that's a good way to remember why TET spells happen. And the reason why is because of the fact that squatting causes an increase in systemic vascular resistance. So increases the pressure in the aorta, so blood is less likely to want to go there. Additionally, squatting increases the venous return to the right side of your heart. So more blood is entering your right cavity, and that increases the space in the right ventricular tract. So it reduces your obstruction. So more blood goes to the lungs to become oxygenated. So I hope that's kind of helped the hardest bit of TOF, I think, to understand. And then the rest of the clinical features are kind of self-explanatory with if you've got pulmonary stenosis, you'll have a harsh ejection systolic murmur. It's also very heavily associated with DiGeorge syndrome. So DiGeorge syndrome, the best way to remember it is it's got issues centrally down. So DiGeorge also has you don't have parathyroid gland production as well, so you get hypocalcemia, and then you've got central midline issues with your heart as well. So it's associated with TOF, VSDs, and things like that. And then the management of non-neonatal TOF is using oxygen to help the cyanosis, to also help with squatting and other things like beta blockers. So the reason why beta blockers help is one of the other reasons for right ventricular outflow tract obstruction is a spasm of this muscle in the intraventricular septum here. So if that occurs, then more blood is preferentially shunted to the left side of the heart, bypassing the lungs. But beta blockers reduce this spasm and relax the muscles in the right ventricular outflow tract, therefore preferentially increasing the amount of blood going to the lungs, becoming oxygenated. Essentially, it needs definitive surgery at 3 to 6 months of age and closure of the VSD, and then relief of this right ventricular outflow tract. And then sometimes in questions, this surgery comes up, this shunt repair, and it's basically seen as a palliative form of surgery if the baby is quite sick or the degree of TOF is really severe because of the right ventricular outflow tract. Another thing that comes up in questions is you've got this chest x-ray showing a boot-shaped heart, which is quite synonymous with TOF. On the contrary, TGA, which is transposition of the great arteries, presents with severe cyanosis within the first few hours of life. It's not really got any respiratory distress or murmur. Essentially, what happens is the aorta comes from the right ventricle and the pulmonary artery comes from the left ventricle. So you've got two parallel circuits going. The aorta carries the deoxygenated blood in this case, and the pulmonary artery carries the oxygenated blood, but they aren't really connecting. This is why it's really important to keep the duct open, because that allows for communication between the aorta and the pulmonary artery. So that's why prostaglandins, which help keep that duct open, it's important to give that. And TGA is also associated with maternal diabetes and VSD and ASDs to help the transfer of blood from both sides as well. And essentially, it also needs surgery by cardiothoracic surgeons, and it needs an arterial switch procedure where they essentially swap the arteries over. I mean, it's obviously not as simple as I'm just describing it there. And then these are some other conditions. I'm very briefly going to go over them, but they're not very high yield for your exams. One of them being truncus arteriosus. So that's essentially when the aorta and the pulmonary artery, they still go to the right place they're meant to go, but when they are just coming off the heart, they've just got like a massive VSD, if you think of it that way, because there's also a VSD usually in this condition anyway. But if you think about the middle bit of the heart, it's just communicating a lot. And the syndrome is associated with, like I said, it affects the middle of the heart. It's associated with DiGeorge syndrome as well. And some signs that you get with it are cyanosis and early heart failure, but the cyanosis depends again on the degree of mixing that's happening. So that's dependent on the changes in pressure. So normally your aorta will have higher pressure than your pulmonary artery, so blood will be going from the aorta to the pulmonary artery. But what ends up happening is there's too much blood going to the pulmonary system, and there's overcirculation that happens there, causing heart failure as a result, like you have in adults. Then tricuspid atresia. So this diagram quite nicely represents what happens. So it's an absence of the tricuspid valve, and it's like the right ventricle is not very well formed either because of this, because there's been no blood supply to it in utero. So it always has an ASD, otherwise it's just not compatible with life. So your blood from the right atrium goes to the left atrium via the ASD. It does not become oxygenated. The only way for it to get oxygenated is if the blood in the left atrium goes down to the left ventricle, and then there is a VSD, because all these conditions, usually the middle, like the ability of the right and left side of the heart to differentiate itself and form properly is not properly done, because there's so many other issues going on, and the body kind of self-realizes that it needs to keep these gateways open, because otherwise blood's just going to get blocked. So blood just finds a way in utero to go where it can go, and that's why these areas are important. So the VSD here allows for communication between the left ventricle and the pulmonary artery, which enables blood to become oxygenated. And then conversely, blood can follow the same route as it would do in a normal body and go left atrium, left ventricle, aorta, but then it can gain access to the pulmonary artery via the ductus arteriosus. So this is a duct-dependent condition, and that's why prostaglandins are needed. So the way for some of the blood from the heart to go to the lungs, get oxygen, and then also come back to provide some mixed oxygenation. And then hypoplastic left heart syndrome, conversely, it's like severe congenital underdevelopment of the left heart. So that includes all these structures in the heart, and it is duct dependent. So it presents 24 to 48 hours of life after the duct is closed, but it's not always symptomatic prior to that. Because of the patency of the duct. So these are all the routes that it can take. So basically, you've got your pulmonary vein; it can go to your left atrium. So the blood is coming from the lungs into the left atrium, and then it goes to the right atrium via the VSD, and then it can follow down to the right ventricle and then go to pulmonary artery to get oxygenation. And then from the pulmonary artery, it goes to the through the ductus arteriosus to the aorta to go to the rest of the body. But as you can imagine, that's quite a long path for blood to take, and there's poor perfusion as a result of this and weak pulses. But prostaglandins are required with a stage repair. So normally what happens now is that these things are kind of picked up in utero because of how good fetal cardiology imaging is, and they're delivered in centres with with pediatric cardiology, so that they can keep the ducts patent while they think of a way to kind of fix and manage these problems. Okay, so our next question is we're nearly at the end, but we've got a 7-year-old child who is seen for a routine examination. They are asymptomatic. On auscultation, there is a fixed split second heart sound and a soft systolic murmur at the upper left sternal border. What is the most likely diagnosis? So the correct answer is atrial septal defect. So this is a quick table that I've created for you just for like pediatric specific heart murmurs to remember. But the fixed split heart sound is very synonymous with atrial septal defect. And the reason for that is because of the fact that one valve closes. So normally respiration changes causes I think it's the pulmonary valve to close prior to the aortic valve. But in atrial septal defect, because of this shunting of the blood, the pressures in both those systems are kept the same. So the valves close at the same fixed rate. It's not affected by respiration. That's essentially what the fixed split heart sound means. And then the reason why the rest of these are wrong is because essentially either the age is not right, or because the murmur would have been different. So talking about septal defects, so essentially these are acyanotic heart disease, so not really associated with cyanosis, and they are seen as a hole in the septum causing a left to right shunting. So essentially, because the pressure on the left side of the heart is more than the right, the blood goes from the left to the right. But then that means more blood is flowing through the lungs, causes pulmonary hypertension, and like in adults, it causes heart failure. And then you get a reversal of this shunt because now you've got the right side of the heart that's got a really high pressurized system because of this pulmonary hypertension, and then the left side of the heart. So the blood will start going from the right to the left. And when that happens, because of septal defects, you've got something called Eisenmenger syndrome, which is not really common anymore, thank God, because there's nothing we can do about it. Essentially, there are 3 main ones you need to know. ASD, so that's basically atrial septal defect, so that's like a communication doorway between your right atrium and your left atrium, and it's much less severe than VSD. And the reason why it's just because of the amount of blood flowing through, essentially. It's not usually symptomatic, and it's only picked up when the kid is a bit older and they're struggling with exercise, or they get recurrent infections, or sometimes it's picked up in GPs by a murmur, and then they get referred to a pediatric cardiologist for an echo, essentially. They may not necessarily need treatment. It depends on the flow of the murmur, the amount of blood's flowing through it. but large defects can be fixed with a transcatheter or surgical closure, depending on the age and other risk factors. But you wouldn't be expected to know that. For your exams, remember that it's not usually symptomatic. It's associated with exercise intolerance, and then remember the type of murmur it is. And then VSD, those are your ventricular septal defects. So you've got a defect in the intraventricular septum, so it allows blood communication from the left ventricle to the right ventricle. So blood goes right ventricle to left ventricle. Wait, blood goes left ventricle to right ventricle, and it's the most common form of septal defect. And the features are poor feeding, poor growth, sweating during feeds, tachypnea, and you get pansystolic murmur. So this is associated mostly with heart failure. And small defects sometimes close by themselves, but obviously the bigger the defect, the more likely there'd be progression to heart failure because there's a higher quantity of blood being shunted, and in a smaller system essentially, because babies still have a small system. And it might be that you manage the heart failure like you would do in adults, similar principle of using some type of ACE inhibitor, some type of beta blocker, but then you would wait till the baby is big enough to be able to do surgery successfully on it, because obviously it is a big surgical procedure. So that's essentially the principle of VSD management. And then you've got AVSD, which is when you get holes in both atrial septum and ventricular septum, and it's also known as an endocardial cushion defect. So you get similar features to VSD, and the same murmur as well. I would say the best way to differentiate it in an exam question, if both of them are presented, is to think about if there's a mention of Down syndrome, because if there is, Down syndrome is extremely synonymous with AVSD. Children with Down syndrome can still have VSD alone, but they're more likely to have AVSD together. That's what would make me go for AVSD. Additionally, if the child is sick and more sick, I'd go for AVSD as well. And then you've got the management of it, which is medical heart failure treatment, and then early surgical repair, less than 1 year of age. And then we're moving on to our last question. We've got a 48-hour-old newborn develops tachypnea and poor feeding. Pregnancy and delivery were uncomplicated. On examination, the infant appears pale with cool lower limbs. What is the most likely diagnosis? So the correct answer here is coarctation of the aorta. So I realized that I didn't give a lot of information in the stem, but it's important to pick up on the small things. So here it would be that because the baby has got cool lower limbs, it's not got enough flow to the lower limbs. And the reason that could be happening is because there's not enough blood flow coming out of the heart. Coarctation of the aorta would also be associated with some other things, which I'll talk about in the next slide as well. So essentially, the most important thing to remember is there's two types. So there's postductal, which is seen more in adults, and then there's preductal, which is seen more in infants. So talking about preductal, which is what the question was talking about first. So it's duct dependent. So the coarctation, so the narrowing, happens before the ductus arteriosus is, and it's important to keep that duct patent because depending on the severity of the coarctation, sometimes some blood can still make its way out of the aorta, but in usual cases, a lot of blood can't make its way out. But the duct allows for some blood to make its way out of the pulmonary trunk into the systemic system. And I understand that that quality of oxygenation may not be good because it's mixed blood still, but it will still be better than nothing essentially. But because not a lot of blood is making it out the heart in the first place, the baby would present with poor feeding, signs of shock, weak femoral pulses, lower limb blood pressures than upper limb blood pressures because there's not enough blood in the lower system. And the management would be to keep the duct patent with prostaglandins and then surgical repair of the coarctation. And long term, it can cause complications with persistent hypertension, aortic aneurysm, because the muscles in this like the aorta itself, not the muscle, sorry, the aorta itself is more prone to coarctation and issues in the future. And it's heavily associated with Turner syndrome and bicuspid valves. So out of all the people that have coarctation of aorta, 85% of them also have bicuspid valves, so it's an important thing to remember. On the contrary, postductal coarctation is seen more in adults and it's more stable. So that's when the narrowing happens after the duct. So the duct's not necessarily needed to keep it patent, and the degree of narrowing is usually much less in postductal. Um, and it's associated with things like headaches, epistaxis, dizziness, leg fatigue, claudication, and reduced exercise tolerance. And then your blood pressure in your arms would be greater than the ones in your legs, so similar to coarctation in the newborn period as well. And you'd also have a systolic murmur because of this narrowing, and it would radiate to the back, which is an important feature to remember. So if you've got a murmur radiating to the back, think coarctation until proven otherwise. And then it would also be repaired with surgery and stenting. And a nice thing to remember is that in a chest x-ray, sometimes you get something called rib notching, which is what you can see by this massive arrow here, where the rib kind of has curved upwards. And the reason why that happens is because of the coarctation, because there's a lack of blood supply to some of the areas around the heart. Now, that depends on the degree of the coarctation. Like arteries and vessels nearby, like your intercostal arteries, start like becoming a bit bigger to help compensate for this, and collaterals start forming off the circulation, and that essentially causes this rib notching to occur. So that's why it's associated with coarctation. But yeah, that's essentially the end of my topic and my teaching. I hope that was useful for you all. If you could please do the feedback form, that'd be greatly appreciated. And I hope I covered a decent amount of neonatology, but there's still a lot to cover, which we'll cover in the next talk as well, in surgery and gastroenterology. So make sure to join for that one. But I hope that was useful. And yeah, thank you for staying.